So now, big pleasure of mine to introduce our next speaker, Dr. Arun Sayal, a classmate, a basketball teammate. Very proud of my classmate for all his fantastic teaching, and my wife says he's very charming.
Thank you very much. My wife doesn't think I'm very charming, but that's okay. Thank you all very much. Thank you to the organizing committee for the invite, as always. I also just got to say, by sitting here and watching all of these, how many people have made their debut on this stage for EMU? And I just want to tell you how impressed I am by everybody who started here. Jonathan, that was fantastic. People yesterday made their first debuts. It's really a testament to the organizing committee to be able to find such talent. It speaks of our profession. It speaks of the depth and the breadth of our expertise. And anyways, just honored to share the stage with all of them. Now let's talk about rolling a joint. Okay, but about ankle injury. So it's not what you thought. Anyways, 4 cases. So I'm going to try to, if we get the advancer to click. Doesn't seem to be. Nope, there we go. Excellent. Okay, just take a look at these for a few seconds. Case 1, 22-year-old injures her ankle, non-weight bearing. X-rays done. These are all isolated injuries. Give you a few seconds to look at these. Case 2, 53-year-old lady twists her ankle, non-weight bearing, tender laterally. Ottawa Ankle Rules indicate an X-ray. Case 3, 61-year-old lady, more significant ankle injury, tender laterally, tender medially, clearly non-weight bearing. X-rays taken. In the last case here, case 4, 81-year-old guy injures his ankle, non-weight bearing, not so sore laterally, a bit swollen, not sore medially, X-rays done. All isolated injuries, all looked after in our emergency department by excellent emerge physicians, all X-rays reviewed by exceptional radiologists. Let's talk about the Ottawa Ankle Rules first, because this is often what we have. How many people use the Ottawa Ankle Rules? Hands up. Sure, that's great. Proud Canadians, absolutely. I've been around for a long time, since the mid-90s. They're a great rule, which I've taught about for years and years and years, and I've taught wrong about them the whole time. There's great value in them. There's no question if we use the rules, we definitely will save time. Patients will have shorter visits in the emergency department if we don't order an X-ray. That makes sense? Totally agree. There's this other benefit of it. There's less radiation. True, but it's a fairly trivial amount of radiation with an ankle X-ray. A foot X-ray, a hand X-ray, a wrist X-ray, an ankle X-ray is 1/100th of a chest X-ray. A chest X-ray is or a CT chest is 70 chest X-rays. So a CT chest is 7,000 ankle X-rays. If you do a D-dimer and get a false positive, right? What's the positive predictive value of a D-dimer? Anywhere from 5 to 20% or so. So for every D-dimer that you get that's positive, maybe 1 in 5 is real, maybe 1 in 20 is real. So there's a lot of tests that we're doing, a lot of CTs that we're doing that really don't, help the patient. And there's a lot of radiation with that. There is not a lot of radiation with an ankle X-ray. So if you want an ankle X-ray, get an ankle X-ray. And don't feel guilty about it, right? So it's okay, so do a history and a physical, and if you want the test, do the test, okay? Lotto Max also, you can win if you don't get a ticket, but guess what? If you buy a ticket, your chances of winning are almost as good as if you don't have a ticket. There's a 1 in 33 million chance of actually winning the lottery if you have a ticket. There's a 0% chance if you don't. They're pretty equal, right? So the amount of radiation of an ankle X-ray, not a big deal. Definitely worry about radiation for CTs and all the other stuff. You know what? Listen, before we used to just X-ray everybody. Let's order a rule so we can actually have some clinical some common sense, use our clinical judgment, and therefore we don't have to just order the X-ray on everybody. Agreed. Let's use a clinical rule. Let's use some common sense rather. That means a history and a physical. Do we really need a rule to help our clinical skills to say if we need an ankle X-ray? Is there like a Collingwood CBC rule? I don't think so, right? Is there a Calgary chest X-ray rule? I don't think so. Like, so we don't need the rule. If you actually want to get better at something, get better at it. Do a history, do a physical, right? And then decide if you want an x-ray. So there's no question the rule will tell you who needs an x-ray, who doesn't, but then you get pretty reliant on the rule and you stop actually. What we've done is we've taken this very good rule of who doesn't need an x-ray and we've misapplied it. If my kid's in grade 5, grade 4 is having trouble with math, he can't do math, he can't do multiplication and division, I could give him a calculator and he'll get the right answer. Or I could teach him math, right? So it's not just getting the right answer, it's just understanding the tools by which you do it. So do a history, do a physical. If you're worried about a test, order the damn test. Don't worry about it. And if you're sending somebody to the fracture clinic with an ankle injury and the rule said you didn't need a test, do the test. Because the ankle x-ray, sure, maybe doesn't show a fracture, but when you're in the fracture clinic, the orthopedic surgeon's eyes on that x-ray see different things. That little tiny avulsion that's well corticated, rounded, not acute, doesn't make a big deal of difference. No problem at all. But what does it say? It says to the surgeon there's a previous injury. Subtle signs of arthritis, a little bit of Achilles tendonitis. These all things, these say something to the surgeon, they don't say anything to us. So the surgeon's gonna order the x-ray. If you're sending to primary care, no problem. You don't need to do the x-ray, right? If you don't want to. I'm not saying the rule is fine, but the rule actually is not about who needs an x-ray. The other problem is our physical exam, when we use the Ottawa Ankle Rules, is we just touch here and here. Excellent. There are lots of areas: Achilles, calcaneus, talus, syndesmosis, distal tibia, the deltoid ligament, which is a medial mal-equivalent injury, which if we don't touch, we don't find. If you want to get better at looking at an x-ray, you get better at assessing a patient. And assessing a patient is not just doing the Ottawa Ankle Rules. That's not what Ian Steele and his team meant. We've taken an excellent rule and we've misapplied it. So twist number one, the Ottawa Ankle Rules are not who needs an x-ray. The Ottawa Ankle Rules are, I don't think you need an x-ray, sir or ma'am, and I've got evidence that supports you don't need an x-ray. Do a history, do a physical. If you don't think they need an x-ray, good. Talk to them and don't order an x-ray. If the patient really wants an x-ray, before I'd argue with them, now I'll just do the damn x-ray. Because the x-ray's gonna come and the radiologist will say there's an age-determinate little avulsion or something, the patient, oh, you missed a fracture, and someone's gonna be all upset, and it's a tiny amount of radiation, it's a tiny amount of cost. Fight where you need to fight. Someone wants an MR of their back? Okay, we're not getting there, right? Like, we'll chat about things for sure. But an ankle x-ray is not where I'm battling patients for sure. Okay, how do you look at an x-ray? So, just to go back for 1 second, we get 3 views. We get an AP view, we get a mortise view, we get a lateral view. And most of us, what we do is say, okay, there's 2 views here, and what do we want to look at? Okay, look at the mortise. Which one's a better view of the mortise? One view is turned in 20 degrees. The one on the left gives you a little cleaner channel between the medial mal and the talus compared to the distal tibia, the tibial plafond and the talus. So that's the cleaner view than this one. Great. So the one on the left is the mortise view. This is the one that we will look at. Okay, there's 2 other views that come along with the right. We need to stop how we think about these x-rays. The most valuable view in orthopedics is the lateral film. The money view is the lateral film. When I work in the operating room, I assist on I assist on trauma cases on Mondays in the OR to keep learning. And I look at the x-rays and I'll see what gets missed in Emerge. I will see what gets missed by our excellent radiology colleagues, right? And what gets missed most, if there's an abnormality, is on the lateral film. We need to spend more time on the lateral film. There are lots of things, so I'll keep normal up there, but you need to trace out the tibia on every view. When you trace out the tibia, you may find a subtle posterior mal fracture. You need to trace out the fibula on the lateral film. Sometimes the only view where you'll see a fractured fibula is on the lateral, and if you don't look for it, you'll miss it. There's a talus. What's the typical mechanism for a talus fracture? It's usually high energy, axial loading, motor vehicle collision, right? They may not be tender medially or laterally. They're tender over their anterior joint line. They're not weight bearing. But if you find they're tender over the anterior joint line, you will look here if you have a history, right? It's not just they're non-weight bearing, I'll do an x-ray. You need a pre-test probability. You can fracture a calcaneus, right? And you see it on the lateral film most of the time. What do you look for? Right, you look for the angle. But what's the story again? Oh, it's someone falling off scaffolding, falling off height. Right, but if you're 80 years of age, you can miss 1 or 2 steps. And because you're osteoporotic, you can break your calcaneus. But if you start at the x-ray and you just touch where the Ottawa Ankle Rules are, we miss these. There's a little triangle in the back. I've taught a fair number of orthopedic courses. I bring on people to help teach. I learn tons from those who help teach a course, right? About this thing called Kager's triangle is one of the things I've learned from them. Kager's triangle is this little triangle in the back, and if you see it's a little cloudy, a little murky, it's a nice little black triangle here that you can see. It's a soft tissue space. If someone ruptures Achilles, has a posterior malfracture, talus fracture, calcaneus fracture, it might throw some swelling into Kager's triangle and it now becomes obscured. So start looking for these things, and particularly make sure the distal tibia is sitting right on top of the talus. These are all really important things to do, right? And now what happens is you're going to look at the lateral film first, then by all means you look at the talus, you look at the mortise view, and in that mortise view, right, the space between the distal tibia and the talus should equal the space between the medial malleolus and the talus. And that's a very important view to look for. If it's shifted by 1 millimeter, which is incredibly subtle, but if it's shifted by 1 millimeter, guess what? Patients will maldistribute the weight by 42%. And that's the reason why, if you have an undisplaced trimalleolar fracture, ortho takes them to the OR. Because when it heals, if it shifts by 1%, patients will maldistribute weight. If you have an undisplaced intra-articular distal radius fracture, nobody runs to the OR. You watch it closely, but you keep an eye on it. But if you have an undisplaced trimal fracture, bimal fracture of the ankle, if it shifts by 1 millimeter, it's a mess. You know, the next speaker is Amal Mattu. If you have a choice in life to speak before Amal or after, it's a good idea to speak before him. But anyways, but he's going to talk about 1 millimeter ST elevation. We need to be experts in finding 1 millimeter. You got to find 1 millimeter on a mortise. We'll show you some of these cases that you just looked at. So twist number 2 for ankle injuries, lateral view first. Go to it first. Take your time. The first time you go through things, right? Just like they were talking about in the last, Dr. Wallace is talking about go through an approach, right? Dr. Kovacs has talked to us for years about have an approach, be ready. Have an approach for ankle x-rays. And when you go through that approach and when you look at it, guess what? It'll take a little bit of time, 10, 15, 20 seconds extra, your next shift. But you'll think about each of these things. You'll think about the story. And then you'll get quicker with it. This 22-year-old, what happened to her? Injured her ankle, seen by a senior resident, one of the R5s in our EMERGE program. The case was reviewed with one of our senior staff people, diagnosed as a severe lateral ankle sprain, discharged home. Radiology recalls it and says, wait a second, that doesn't look normal on the lateral. In green is what normal looks like. That talus isn't quite normal. Look on the AP. It's hard to recognize abnormality unless you know normal. If you don't normally look at a talus, it's hard to pick that up. But if you also did 2 things, one called a history, 2 called a physical, before you looked at the x-ray, you might recognize what happened. And what happened was she fell off a garage. 8 feet, non-weight bearing, injured her ankle, she axially loaded. Where is she tender? She's not tender. The resident, mid-fibular squeeze test, a Lisfranc non-tender, lateral mal, medial mal, but never touched the anterior joint line. I'm not critical of the resident. I probably trained that resident a few years earlier, and I never talked about touching the anterior joint line. I never did it. It's only by seeing these cases and how they're missed that I recognize this stuff. She comes back, she gets a CT. That's her. That's the same patient. Smoked talus, right? Dusted talus. In Australia, a munted talus. I still have to look up munted, but it sounds bad. That's a terrible talus. That's a bad fracture and a bad bone. She ends up with an operation. She'll never have a normal ankle again. Not because it got missed for 8 or 10 hours in the emergency department, right? She went home and came back because she just has a bad fracture to a bad bone. 53-year-old injures her ankle. What's the first view we should look at? Go to the lateral view. How many of you where you worked, a radiologist may actually order, may have an x-ray interpretation on a plain film before the patient leaves EMERGE? Anybody? Right. And if it's back, chest x-ray, normal, ankle, and whatever, undisplaced fracture, mortise congruent, our tendency is to look at the report and not look at the film. Because if a radiologist said chest x-ray is negative, what's the chance I'm going to find something? It's actually not bad. The chance is reasonably good. The sensitivity of a radiology report is only about 80% if there's an abnormality. They miss 1 in 5 abnormalities. So let's look here. Look at the lateral film. What should you do? Trace out the fibula, and then you'll see the fibular fracture that the radiologist saw. Hands up if there's a posterior malfracture. Yeah, there is. Posterior malfracture, subtle, but it's there, missed by radiology. There's even something else hanging out the front. Not exactly sure where that's from, but that's not normal. It's also not commented on in the radiology report. But that posterior mal, if you see that lateral film, lateral mal, posterior mal, there's badness in that angle, in that ankle, definitely back slab, non-weight bearing, you're gonna talk to ortho at a reasonable hour. Kager's triangle, what does it look like? It's actually obliterated. But I never looked at it for years, right? But that's another little clue that something's going on. Which is the better view, the mortise? Number one is the cleaner view, or number two? It's number two. So let's focus on number two. What do we want? We want the distance between the medial mal and the talus to equal the distance between the distal tibia and the talar dome. These are very close, but I'll tell you, these arrowheads are the exact same size. The gap is there. This is a very subtle shift. What did the radiologist say? Ankle mortise congruent. Radiologist was wrong. This is not only lateral mal, posterior mal, and shifted, subtle as it may be. I'm not saying the standard of care is to pick that up, right? I'm not saying the average emerg-onc would pick that up, but that's not normal. But if someone touched that patient, there'd be tender wear, not on their medial mal, but over their deltoid ligament, because there's no medial fracture. But if all we do is the Ottawa Ankle Rules, we miss the clinical clues. 61-year-old injures her ankle. It's a bad fracture. You can see that if you want to call it a Weber C, everyone gets hung up on all these terms. Who cares? There's a fibular fracture higher up. We can see that. There's a medial mal fracture. Hands up if you see a posterior mal fracture. Excellent, right? So this gets, it's splinted. Post-splint done because it's pretty unstable. Take an x-ray, make sure, no problem. Talk to ortho, excellent. This is surgical, great. Keep them NPO, I'll see them the next day. We go to the OR, fix it the next day, no problem. The surgeon's like, there was a problem. What was the problem? On the post-reduction film or the post-x-ray, this ankle is not sitting normal. This is normal. And what's happened is the posterior fragment is sitting over the talus, the anterior is not. This is sublux posteriorly. This is a problem because that distal tibia is grinding on what? It's grinding on the talar dome. And if it sits on that talar dome, it can cause an ischemic necrosis of the talar dome, which knocks off some cartilage, which is a weight-bearing surface, which will cause arthritis down the road. Subtle? Absolutely, right? But your job is to think about this, how important that lateral film is. 81-year-old guy, what happens to him? Slip, non-weight bearing, diagnoses a lateral ankle sprain. Be careful diagnosing older folks, 80, 75, 80, 80, whatever, with the soft tissue injuries of their ankle, soft tissue injuries of their knee. They twist, they have weak bone. This guy missed what? 2 steps. Laterally, he's quite swollen. Radiology, swollen laterally. But if anyone examined him, guess what? He's sore as hell in his calcaneus. And he's got a fractured calcaneus that's easy to miss, right? I can't tell you how many of these I've missed, because if I missed it, I send it to ortho, and ortho doesn't tell me I missed it before. So I'm sure I've missed tons of these. But if I just do the Ottawa Ankle Rules, I go, oh, I need an x-ray. But I don't even know where the hell to look on the x-ray because I haven't touched them. The Ottawa Ankle Rules have nothing to do with an exam. Last case, 55-year-old. There's no diagnostic dilemma here, right? This ain't so subtle, okay? 55-year-old, this is a great case seen by one of our I work in a great group with real superstars. Michael Mish, one of them. His case, 55-year-old. If you saw this at 2 o'clock in the morning on your next shift, hands up if you'd reduce this. Right, shout out why. Why are you reducing it? Louder, sir?
It's probably tenting anterior.
It might be tenting, yeah, so you can check their skin and see if it's blanched. Excellent, so make sure the soft tissue's fine. The necrosis of the talus, sure, watch out for that. If it swells more, right? It's a real problem with ankles. Who's heard of something called fracture blisters? Who's seen a fracture blister? Go to the OR once in a while, and you'll see a mal-reduced fracture end up with a fracture blister. We wrap it if we don't, we'll talk about this, I'll show you it. But this is why we're minimizing pre-op swelling. Might it hurt a little bit to reduce it? Perhaps. It'll hurt a hell of a lot more if we don't reduce it, right? So this needs to be reduced. There's pressure, that distal tibia. Forget about if they're weight-bearing or not. That distal tibia is grinding on that talar dome. And if you leave that overnight, this patient for sure will have a necrotic talar dome. Maybe they pounded the talus on the way out. Nothing we can do about that. But we want to reduce this to put it back in. You can grab the big toe, and that usually works. And if it doesn't, just flex the knee. It's a really nice little tip to reduce an ankle fracture dislocation. Flex the knee, relaxes gastrocs, makes it easier to reduce. But Michael, as usual, does a phenomenal job. Timely reduction done to protect the soft tissues. Not saving the patient from an operation, patient's getting an operation. Saving the patient from complications of an operation. These are fracture blisters. I go to the OR, I'll tell you honestly, total hips, total knees, if they're ever stuck and I do them, I hate them. They bore the hell out of me. But the emerge cases, the fracture cases, this is where we learn. And just as Dr. Wallace was mentioning earlier, right? Sometimes, you know what, I haven't intubated for a while. I'll just go to the head of the bed, I'll intubate, and then I'll go back outside, we'll scrub, and we'll do the case. Right? It's another way. You learn from the surgeons. I learn a ton, not even in the OR. It's nice to see the pathology. It's at the sink when we're scrubbing, and I hear why they're here and what's happened. This is a case from Collingwood, one of our docs who teaches the course, right? Again, fracture blisters. And if there's a blister there, it's like a burn, and the surgeon can't make the incision where they want to. These reductions that we're doing in emerge are not to save the patients from operations for lower extremity injuries. It's to protect the soft tissue. They are soft tissue reductions. If their patients are older and they've got poor quality skin, old patients don't get compartment syndrome, the skin tears, secondarily opened, risk of infection. If you're younger, you don't get compartment syndrome around an ankle. Compartment syndrome is muscle ischemia. There's no real muscle around an ankle. But there's so little subcutaneous tissue that when pressure builds, it comes out, it's almost like it burns the skin. And this is why you get these blisters. And these blisters are a disaster for patient because the surgeon can't make the incision there. It means it's so swollen, they won't even be able to cut, because if they cut, all the fluid comes out and they won't be able to close skin. If you put so much tension on the skin, it'll just tear. And if there's already so much tension that it's causing the blistering, you know it's not normal. And for all patients, when you do this reduction, you're protecting the cartilage, you're minimizing swelling, you're minimizing pain, which are really important. So twist number 3, reduce ankles to reduce complications. Understand why. Don't just do it because somebody said you should do it, because you might do it then next week or 2 weeks from now, but 4 months from now when it comes in at 3 in the morning, you're like, I don't want to do that. That looks like it'll be painful. If you understand the why, it'll motivate you to do it. So twist 1, Ottawa Ankle Rules are not who needs an x-ray. They are support if you don't want to order an x-ray. Do a history, do a physical. If you want an x-ray, order an x-ray guilt-free. But if you don't want an x-ray, now apply the rule. If the rule agrees with you, great. You can save the system an x-ray. Twist number 2, look at the lateral view first. Spend some time, dig around, fish around at this, look at it, make sure you understand it well, then go look at the mortise, then go look at the AP. Look at all the views. Go to the lateral first. In orthopedics, a lateral view of the ankle, lateral view of the shoulder, lateral view of the elbow, lateral view of the wrist even. Those are the money views. And twist number 3, reduce ankles to reduce complications. Thank you all very much.